We are going to talk about cirrhosis and end-stage liver disease. Here are your objectives related to cirrhosis. We know that our liver is responsible for over 500 different functions in the body, and I'm going to do a quick patho review just to show you why liver patients present the way they do. And they do because when a patient has end-stage liver disease, their liver is unable to carry out its vital functions, which can include detoxifying ammonia. Remember, the liver is going to break down ammonia into a less toxic substance called urea, or your blood urea nitrogen. And the reason we produce ammonia in our body is through normal protein catabolism. So our body breaks down protein, and as a waste product we get ammonia, and ammonia is a very potent neurotoxin. Again, if you don't believe me, go drink the bottle of Windex and see how well your mental status is. I'm sure you're not going to be walking in a straight line. And ultimately, your liver is going to work with your kidneys to eliminate this urea through the body through urine. Our liver is also responsible for drug metabolism. So, what the liver is going to do is it's going to chemically alter drugs into their metabolites or inactive forms, which is ultimately going to facilitate their detoxification to the body and ultimately their excretion or elimination from the body. The liver also plays a role in regulating glucose. When we don't need glucose or our blood sugar is high, what the liver is going to do is it's going to convert this excess glucose into glycogen, and it's going to store it in the liver for a rainy day. Let's say I have to go for a little run, or I need a test and I need some extra fuel. Then what your liver will do is it will release this glucose back into the blood to help maintain our blood sugars. And this is one of the many reasons why, even if we're not taking adequate nutrition in, our blood sugar just doesn't drop. That's because our liver is doing its role in helping keep homeostasis. Even when we don't have fuel, we at least have some reserve. And your liver can also create glucose from other substances such as lactate. And lastly, your liver is also responsible for a type of ABCs, your albumin bile coagulation factors. Albumin is just a colloid. So what it's going to do is it's going to pull the fluid into your vascular space. Because remember, normally we have something called hydrostatic pressure, which is constantly trying to push fluid out of our vascular space into the interstitial space. Well, that colloid oncotic pressure caused by large proteins is going to oppose that. And these are going to be counter forces. And this is why you just don't have fluid just leaking out everywhere. And albumin is also a key player in maintaining our calcium. About 45% of our calcium in our body is going to bind to albumin. And our liver is also responsible for producing bile, which is going to break down various substances in the body, such as fats or our bilirubin. Remember, bilirubin is just going to be that byproduct of red blood cell production. And what our liver is going to do is it's going to use bile to eliminate this bilirubin from our body through the bowels. And then there's the C, the coagulation factors. All of our coagulation factors except 3, 4, and 8 are going to be synthesized in our liver. So the liver is going to play a major role in bleeding and clotting. So when a patient has liver failure, they are going to have coagulopathies that form. Cirrhosis is an irreversible and progressive condition that is going to ultimately lead to liver failure. And cirrhosis is caused by chronic inflammation to the liver, which is going to lead to scar tissue. And as we know, scar tissue is not functional. And over time, the liver is going to become hard and nodular. And eventually, the liver is not going to be able to do its normal functions, leading to decompensated cirrhosis. You have 3 types of cirrhosis. The first is going to be your post-necrotic cirrhosis, and this is going to be characterized by that chronic inflammation and fibrosis that I was talking about. It's going to be caused by things such as chronic viral hepatitis, so your hepatitis B and C, and in some situations D, and hepatotoxic medications when we're constantly exposed to them. And we know there's a lot of hepatotoxic medications such as acetaminophen. And this is going to ultimately disrupt the liver's function. Then you have biliary cirrhosis. And biliary cirrhosis is also called biliary cholangitis. And this is going to be inflammation of the bile duct system. And usually this is going to be caused by an autoimmune disease. However, it can occur secondary to bile duct obstructions from things such as gallstones, which ultimately that obstruction will also lead to that inflammation, fibrosis, and scarring. And then you have your alcoholic cirrhosis, and that's going to be caused by chronic alcoholism. We know that alcohol is an extremely hepatotoxic substance, which is going to ultimately lead to fatty liver disease, which will progress into cirrhosis. Risk factors for cirrhosis can include things such as that chronic viral hepatitis, autoimmune hepatitis, certain genetic diseases, alcohol use disorder, non-alcoholic fatty liver disease, and damage from those hepatotoxins. And a lot of medications are hepatotoxic in nature, and chronic use of them can ultimately lead to chronic hepatitis and cirrhosis. Then we know we can have that chronic biliary disease or obstruction and cardiac cirrhosis. And this is going to occur from right-sided heart failure. What happens is you have so much pressure in your portal system that is going to be caused by that backflow of blood from the heart into the portal system, because that right ventricle is not able to adequately pump blood into the lungs. wanted to talk a little bit about non-alcoholic fatty liver disease and NASH. And that's because both of these conditions are on the rise. And that is because of the lifestyle factors that we choose. Non-alcoholic fatty liver disease is going to occur because the liver is going to store excessive amounts of fats from the body. And this is going to be completely unrelated to alcohol use. And it's going to be related to things such as obesity, hyperlipidemia, high cholesterol, high triglycerides, metabolic syndrome, diabetes type 2. And NASH is just a more severe form of non-alcoholic fatty liver disease. And that's going to be caused by increased liver inflammation, hepatocyte injury, and liver fibrosis. So it's just going to be a continuum of that liver damage, which will ultimately lead to the cirrhosis. Often, patients in the early stages of cirrhosis are going to be asymptomatic, and that is because of this lovely thing called compensation. As the liver starts to become more fibrotic and scarring, there's still functional parts of the liver that are going to take on the extra load so that the liver can perform its normal function. In fact, most of the time, patients will not start exhibiting symptoms of cirrhosis until about 80% of those hepatocytes are destroyed. And initial symptoms may be very nonspecific, such as fatigue, malaise, decreased appetite, weight loss, abdominal pain. And often you'll see hepatomegaly. And this can go undetected sometimes because remember, in a normal person, the liver's not palpatable. Generally, we can only palpate it in thinner individuals. And with our larger and obese populations, even having hepatomegaly, that may not be something we could just easily detect. And as cirrhosis progresses, and those hepatocytes are no longer functioning, the patient is going to go from compensated cirrhosis to decompensated cirrhosis. And something called portal hypertension is going to develop, which is going to lead to multi-system effects. As we discuss the clinical manifestations of liver failure, I want you to ask yourself, why is this patient experiencing it? What liver function is being disrupted? Patients who have liver failure will often become jaundiced, and that is because they have increased bilirubin. And they'll have dry skin and pruritus, and that again has to do with the toxins that are remaining in the body. Patients may have something called asterixis, and that is just going to be a hand flapping tremor of the hand caused by high levels of ammonia. And remember, our coagulation factors are going to be synthesized in our liver, all of them except 3, 4, and 8. And because of this, patients with liver failure, you'll see a lot of ecchymosis, petechiae. They may have episodes of bleeding very easily, like such as brushing their teeth. You may notice bruising. They may have palmar erythemia, altered mental status, and that's called hepatic encephalopathy in this case. And hepatic encephalopathy is just a fancy way of saying a change in structure and or function of the brain. And remember, ammonia is a neurotoxin, so we're going to be all altered. You're going to have things such as peripheral edema and abdominal ascites. And this is going to be partly because we have a lack of albumin, which is that opposing force to that hydrostatic pressure. So now everything's leaking from the vascular space into the interstitial space, which can lead to things such as hypotension. We're going to have fluid and electrolyte imbalances. A lot of times you will see hypokalemia, you will see hypocalcemia, hypoalbuminuria. I can never say that word. Low albumin. It's so much easier, isn't it? We'll see things like leukopenia, and that can lead to increased risk of infection. And we can see things such as hypoglycemia and hyperglycemia. And a lot of times we'll also see nutrition or muscle wasting in this patient population. You will see a variety of different tools utilized in the diagnosis of hepatitis, and they're going to be very patient specific often. For example, if viral hepatitis is suspected to be the underlying cause of cirrhosis, a hepatitis panel will be ordered. And you would expect a patient to be positive for hepatitis B, C, or D. Also, we are going to look at the patient's liver enzymes, your AST and your ALT, and your ALP. They will generally be elevated. I want you to know that ALP is sometimes normal in cirrhosis unless it's caused by that biliary obstruction. And over time, your AST and your ALT may actually normalize. And that's because the liver cells are so damaged that those hepatocytes are no longer responding to insult or injury. You would expect a patient's total bilirubin to be elevated. Remember, the liver is going to break down bilirubin and it is going to be excreted in bile. But when the liver isn't functioning, the bilirubin is going to have no way to get to the bowels to be eliminated from the body. And that's where you'll see the jaundice come from. You will see the ammonia will often be elevated. And remember, the liver breaks down ammonia, and ammonia is just a normal waste product of protein metabolism. A patient may also have an elevated BUN because remember, when the liver generally breaks down ammonia, it breaks it down into a less harmful substance called urea. And ultimately, your urea is going to be eliminated through urine with the kidneys. So that is going to be your blood urine nitrogen. You will also see that a patient's albumin and serum protein are often decreased. Remember, the liver is going to synthesize those plasma proteins like albumin. CBC, you may notice that the H&H is low or that the patient is thrombocytopenic. You may notice that the PT and INR is increased. Remember, all your coagulation factors except 3, 4, and 8 are made in the liver. So when the liver is damaged, you're going to have a negative effect on the body's ability to coagulate promptly, which can lead to prolonged bleeding. A patient may have an endoscopy. Um, that can see things such as varices, ulcers, and GI bleeding, which may be associated with liver failure. A patient may have a liver biopsy, and this is going to be the gold standard to differentiate like cirrhosis from hepatitis and find out many of the underlying causes, such as the autoimmune disease. However, this is very, very invasive. So often you can see the cirrhosis on the CT, ultrasound, MRI, and a patient may also go for a HIDA scan. Cirrhosis can lead to portal hypertension, but there are other causes of portal hypertension. Remember, portal hypertension is just a clinical syndrome that is characterized by increased hydrostatic or increased blood pressure within that portal system. And portal hypertension is going to be classified by the origin of that source of restriction that leads to that hypertension. For example, you can have prehepatic causes, so anything before the liver, which is going to lead to restricted blood flow or an obstruction of blood flow to the liver. And that can include things such as your portal vein thrombosis or your splenic vein thrombosis. You also are going to have post-hepatic causes. So that's going to be anything after the liver, where you're going to have a backflow of blood back into the portal system, leading to that portal hypertension. For example, your right-sided heart failure or your constricted pericarditis can do that. But you will also see, most commonly in the United States, you will see the source is going to be intrahepatic, so directly in the liver. And that's going to be caused by things such as the chronic hepatitis, which can lead to the post-necrotic cirrhosis, the alcoholism, the non-alcoholic fatty liver disease, which can ultimately lead to cirrhosis. So that's going to be damage inside of the liver itself to the hepatocytes, which again is going to lead to a restriction and prevent adequate blood flow through the portal system.
Now, as a patient progresses towards advanced cirrhosis, I can guarantee you they are going to develop portal hypertension. And portal hypertension, although asymptomatic, is going to lead to a variety of complications that we associate with acute decompensated liver failure, such as your splenomegaly, your ascites, your esophageal and gastrointestinal varices, and your hepatic encephalopathy, your hepatorenal syndrome. And portal hypertension is exactly what the name implies. It is an increased pressure within the portal vein. And your portal vein is the vessel that is going to connect the outflow of the GI tract and the spleen to the liver. And portal hypertension is going to be caused by restricted blood flow through that portal vein. portal hypertension is going to be focused primarily on medical management, where the goal is going to be to address the underlying issue if possible, support the body, and provide medications and support to lessen the severity of the portal hypertension. And usually you will see patients prescribed with non-selective beta blockers. We want a non-selective beta blocker because these drugs are going to work outside of the heart. So they are going to reduce the pressures in other organ systems, such as the portal system. And ultimately, we want to treat any associated complications. We may do a paracentesis or a transjugular intrahepatic portosystemic shunt, or a TIPS procedure. Now, this procedure is very, very complex. It's going to be done in interventional radiology. And this procedure is going to help alleviate the high pressures in the portal vein. It's going to help decrease the emergence of varices and ascites. So with this procedure, a channel is created through the liver tissue with a needle. And a stent is going to be inserted into this channel to allow blood to flow directly from the portal vein into the hepatic vein, bypassing the cirrhotic liver. Now, the biggest complication of this procedure is going to be stenosis or occlusion of that shunt, backing it up. And also, we are going to be bypassing the liver. So, patients are at greater risk for hepatic encephalopathy because the blood is not going to go through the liver where detoxification is going to occur. So those potent neurotoxins like the ammonia are going to go straight into that blood-brain barrier. However, this therapy could have long-term survival. So it's often used in palliative care and symptom treatment until a transplant becomes available. Now, one of the major contraindications of this is going to be significant hepatic encephalopathy. If a patient already has that, if we place the shunt and bypass the liver, this is going to get progressively worse and can progress to seizures, coma, death. And when we have such high ammonia levels, it can actually cause cerebral edema. So we have to look at the risks and benefits of this procedure. Remember, with portal hypertension, we're going to have that increased hydrostatic pressure within the portal veins. And then we have these engorged collateral vessels that have formed. Well, this pressure is going to cause a leakage from the vascular space into the extravascular space. And in this situation, it's going to be into the peritoneal cavity. Now, other conditions can also cause ascites, such as constrictive pericarditis, right-sided heart failure. Because remember, these conditions are going to cause a backflow of blood and venous congestion. And it can cause significant congestion within that portal vein, and you will have that same leakage. You also see this condition in starving children. You remember all those commercials about for 20 cents a day? You're like, the kids are so skinny, but they have those very, very large abdomens. And that's not meat, that is fluid, because they have no albumin, they have no protein. They are wasting away their muscle just to survive. So you will have that same leakage there. Clinical manifestations of ascites may be a distended abdomen. It may feel a little taut. Vowel sounds may be muffled, distant, hypoactive, or you may not even be able to hear them. And if your patient needs a bladder scan, it's going to be highly inaccurate. It's going to pick up that peritoneal fluid. Now, complications of a ascites can include fluid and electrolyte abnormalities, hypovolemia, hypokalemia. Patients may show signs of hypovolemia, but they have massive fluid overload. They have like +3 pitting edema, scrotal edema, and severe ascites. And that just has to do with the location of the fluid. They are intravascularly dry. They have no preload because it's all leaving that vascular space. But they have so much additional fluid in their abdomen and extremities. One complication of ascites is going to be flood syndrome. And this is a rare complication where a sudden rush of ascites fluid is going to cause a spontaneous rupture of the umbilical hernia. And this is going to cause spontaneous movement of that ascites fluid, and it's often termed a spontaneous paracentesis because, hey, if you didn't do the paracentesis, the patient's body did it themselves. And this can follow a sudden increase in intra-abdominal pressure with coughing, vomiting, and straining, or rising from a seated position. And this increase of pressure can ultimately cause that rupture. And complications of this can be a bowel incarceration, hypotension and shock, cellulitis, peritonitis, sepsis, ulceration, and necrosis of the umbilical hernia. So it's very important to monitor for these symptoms. Another type of complication that you may see is going to be spontaneous bacterial peritonitis, because you have all this fluid in your peritoneal space, and this can proceed with infection, inflammation of that peritoneum, because think about all of those organ systems in that cavity and how the bacteria can just spread. And this can lead to sepsis and ultimately death. Now, we treat ascites. Ultimately, we want to treat the cause of the ascites. And in this situation, portal hypertension, maybe a TIPS procedure. Maybe we want to give beta blockers to try to reduce that pressure and lessen the severity of the ascites. You may also see albumin given, so we can try to put the fluid back in the vascular space by increasing that oncotic pressure. And then once we do that, you may see them administer diuretics. It's usually going to be like potassium sparing because the patient's hypokalemic, or You may fix the potassium and do something like a loop diuretic, which is going to be more powerful and produce more urine. Or when this fails, we're going to do the paracentesis. A paracentesis is a needle that is inserted into the abdominal wall with a catheter to remove excess fluid from the peritoneal cavity. This can be done at bedside. It can be done in interventional radiology. Patients should be positioned in a supine and slightly recumbent position so that the fluid can be drained appropriately. You may see the patient also placed in Fowler's position. So, patients who progress onto end-stage liver are going to need multiple paracentesis. Some patients even need them once or twice a week, and we can remove several liters. I know some recommendations will say like 5 liters, but you'll see much more done in the clinical setting. We had 11 removed recently from someone in the ICU. Now, nursing considerations for this procedure. You are going to assist the provider. Obviously, have the patient empty their bladder prior to the procedure if they are awake, conscious. If not, insert a Foley. Or they could be in hepatorenal failure, and we'll talk about hepatorenal syndrome here in a second. And they may have little to no urine in their bladder anyway. It's important to monitor vitals before, during, and after the procedure, and to assess for signs of hypovolemia or fluid shifts, because this procedure can exacerbate fluid shifts. You want to monitor that puncture site for bleeding or fluid leakage. Think about it. There's going to be an alteration in the coagulation pathway, and these patients are at risk for prolonged and worsened bleeding. And a lot of times for the fluid that we lost, because remember, the patient may need more vascular fluid, we will replace this fluid with albumin so that we can try to pull more fluid into that vascular space. Now, remember, varices are going to form and serve as collateral vessels from the portal circulation to systemic circulation. But remember, these are going to be weak and fragile. And since we have that increased vascular resistance that veins normally don't have to go against in that system, these vessels are going to engorge and swell very easily, making them even weaker. Patients with varices are generally asymptomatic until they rupture. Occasionally, you'll have a patient with like a small varices that's slowly starting to engorge. And you may see some tarry stool, some darker bloody emesis, something like that. There may be some clues, but 99% of the time that's not happening. But we know that patients with portal hypertension, if their portal pressures are 10 or more, they definitely have varices. And patients that are at high risk, they may go in with an endoscopy, a camera, look around just like they do in the cath lab, and then they will do some banding. They'll put bands on it and ligation so that these varices do not rupture. You will also see medications like propranolol given. We want to reduce that portal pressure. We want to reduce that pressure in those varices. You can also see octreotide is frequently given. And octreotide is a synthetic somatostatin hormone, and that is going to reduce the blood flow to the gastrointestinal tract. So it's going to reduce that portal blood flow. And we want to do that because we don't want to keep adding pressure from all that fluid to these areas. Because think about it, get a water balloon, not literally, but and just keep filling it up, fill it up, fill it up. What's going to eventually happen? It is going to rupture and shit is going to hit the fan. So when we're filling up that water balloon and we keep adding more and more water, eventually we are going to have so much water in there that it is going to surpass that balloon's abilities and it is going to rupture. And an esophageal gastric variceal bleed will do the exact same thing. This is a medical emergency. It is the most life-threatening and common complication of cirrhosis and portal hypertension. And your clinical manifestations may surprise you a little bit with that massive GI hemorrhage because this is a vein. Remember, normally arteries are going to be associated with more severe bleeds because it's a high pressure system. Well, these veins have now become a high pressure system just like the arteries. So there's so much pressure that they are going to be bleeding tremendously. Now your treatments are going to be your supportive therapy, your blood products. I'm sure your patient's going to be on massive transfusion protocol. You may deliver the octreotide. You may start vasopressin, another gastrointestinal reducing vasopressor. So it's going to reduce that perfusion to the gut and hopefully reduce some of that pressure. Now you're going to be giving blood, you're going to be getting labs, you're going to be doing a lot. But this patient has suddenly become a unit patient because this patient is going to be so sick and they are going to be rapidly deteriorating. And you're going to need all the help you can get. But the goal is to stop the bleed and to treat the underlying cause of that bleed. But the patient is usually too hemodynamically unstable just to get wheeled onto IR. They will code in the freaking hallway on the elevator. So we're going to put something in place, a balloon tamponade, to compress on that esophagus and hopefully slow down or stop that bleed until we can stabilize this patient. Now, the provider can insert this at bedside in critical care. But first, you're going to do a gastric lavage so you can see and ensure that you are visualizing the right location of this device. Because if it's not placed properly, your patient is going to die. So, what it is a nasogastric tube or an orogastric tube if the patient's already intubated, and if they're not, they're at higher risk for aspiration. A lot of times we'll emergently intubate the patient and start this balloon tamponade because we don't want all of that vomit going straight into the lungs, because now we have aspiration pneumonia. And now this balloon is going to have multiple lumens, and what's going to happen is the gastric and esophageal balloon are going to be inflated to apply that direct pressure on those bleeding varices and hopefully achieve hemostasis. And you're going to be doing this at the same time that someone's requesting blood. Again, this is a group patient. Now, once we have slowed down that bleeding, that's when the patient will be stable enough to try to correct that varices by banding it. With these tamponade balloons, it's going to have a nanometer, and we are going to put air in it. And it's going to be secured, usually with a helmet. Yes, a helmet. Or sometimes you'll see like a saline bag and it'll be hung in the air if you don't have immediate access to a helmet. And this is to keep it in place and ensure that it's not migrating out, because then it can no longer be effective. And you're going to have that one lumen covering the gastric area. You'll have that lumen on the esophagus. And hopefully you can achieve that hemostasis.
Hepatic encephalopathy is a severe but potentially reversible complication of cirrhosis and portal hypertension. We know that one of the liver's main function is to metabolize drugs and toxins. Well, we also know that when a patient has liver failure, they're going to make those collateral pathways and those varices. So blood is going to shunt away from the liver, and it's not going to pass through the liver so that it can be inactivated. And then these harmful substances such as ammonia, urea will go into the blood-brain barrier, and they are going to have neurotoxic effects. And sometimes they can even lead to something called cerebral edema, which is going to be swelling of the brain, which can lead to ultimately herniation and death. So it's very important that we recognize signs of hepatic encephalopathy. A patient may have a change in mental status. They may have those hand flaps. You may notice that the patient is hypoactive, or they may be hyperactive. Their speech may be slurred. A lot of times it can seem similar to like signs of a stroke. And how do we treat this? Well, for one, lactulose. Lactulose is going to bind to the ammonia, and you're going to excrete it through the bowels. You can also use non-absorbable antibiotics such as rifaximin and neomycin. And another way is to restrict protein. This is the only time you begin to start restricting protein, because you don't want that buildup of ammonia. The patient is protein deficient. They don't have albumin and other plasma proteins, but you're going to worsen that hepatic encephalopathy if you give them their needs. It's like you have to think about the risk versus the benefit.
Now, hepatorenal syndrome is potentially reversible if you can address the underlying mechanism. And remember, a lot of times patients with liver failure, they're going to have that portal hypertension, especially if it's advanced. That's like a sure thing. That's one of the very, very few certains in life. And they're going to have that leakage from the capillaries. So they're losing their intravascular volume. So this decrease in preload is going to result in hypoperfusion of the kidneys, which can rapidly progress to intrarenal damage and acute tubular necrosis. But if the arterial blood volume is restored, perfusion is restored promptly, this may be reversed. Now, patients that develop hepatorenal syndrome will often manifest with symptoms of an AKI. They may be oleuuric, they may even be anuric, and they may require CRRT dialysis is because they're so hemodynamically unstable. I just wanted to discuss a few pharmacology considerations with you. Our liver is going to be our primary site for drug metabolism. So, when we have liver dysfunction, that can increase the half-life and plasma levels of certain drugs, just like when a patient has renal failure. Certain dosages of medication or frequency may need to be adjusted for this consideration, and we just need to be very careful when giving opioids, sedatives, barbiturates, because some of these medications can be fairly long acting, and it can put the patient at risk for respiratory compromise, especially if they've had some varices rupture and they probably aspirated a lot of blood. You don't want to further worsen that respiratory system. So just please be cautious when administering these medications in this patient population. Now that we have finished discussing the pathology of liver dysfunction, I did want to review some frequent medications again. And some of these I've already reviewed in full, so I'm not going to go over it again and be too redundant. But you remember we have our albumin to pull it back into the vascular space. We want that fluid in the vascular space because it's usually seeping into the interstitial space and the patient is hemodynamically unstable. Now, we may try to administer diuretics after we pull it into the vascular space so that we can just try to achieve that balance. We have the non-selective beta blockers for the portal hypertension and varices. Now, patients with liver dysfunction are usually pretty malnourished. They have poor appetites. Some of them could have been alcoholics, and they were getting their nutrition from beer, which is none. And you may see vitamin like A, C, and K given, and you know that vitamin K plays an important role in stopping bleeding. Now, your patients with liver failure often have a deficiency in thiamine and folic acid, which can lead to Wernicke's encephalopathy. And we treat this by giving thiamine and folic acid. Patients may be on PPIs, H2 blockers to help protect and reduce that stomach acid. Acetylcysteine is going to be your reversal agent for your acetaminophen overdose. And remember, octreotide is going to cause vasoconstriction, reduce that blood flow to the GI system, which is especially important during certain complications of liver failure, like varices. You don't want to increase that pressure. You want to shunt that blood away. When treating cirrhosis in end-stage liver, our ultimate goal is going to be to treat the underlying cause, if possible, and medical and symptom management. You may see things done such as an ERCP, where stents and drains may be placed, the balloon tamponade device, lipid-lowering methods and diet, nutritional supplementation. We need to offer the patient periods of rest to help manage their fatigue. And remember, patients who have liver failure are going to have those buildup of toxins. So we need to offer appropriate skin care, such as moisturizer for that dry, itchy skin, or offer frequent oral care. We can do things such as a paracentesis, which can promote comfort. Obviously, alcohol avoidance. The TIPS procedure is our last-ditch effort before we look into a curative treatment, such as a liver transplant. Now, patients with liver failure are at high risk for airway, breathing, and circulation compromise. Think about it. If a patient has developed a varices that is ruptured, then they may have vomited blood, aspirated it. That could put their circulatory system at risk too, right? They could be hypotensive and shock. These patients may have that hepatic encephalopathy to where they are unable to protect their airway. They may have developed hepatorenal syndrome to where they're going into more and more fluid overload and it's backing up into their lungs. It is very important to document accurate I's and O's. You need to do daily weights on these patients. That is going to help determine their fluid status as well. You may need to measure the abdominal girth to see if it's getting worse. Is this ascites getting worse? Measure and characterize the type of peripheral edema. Assess for bleeding, varices, hemorrhage, even like your IV sites, because remember, your clotting factors are altered. You may need to do continuous neurological exams because you remember they can develop cerebral edema, which can be life-threatening. Now, these patients are going to be very, very swollen and their skin is going to be so fragile. So you need to assess for skin breakdown, edema. You need to assess their nutrition status. You need to continuously monitor the labs, vitals. You need to assess for signs and symptoms of infection. Remember, we have that splenomegaly that can put a patient at risk for decreased white blood cells. It can increase their risk of infection. Patients with ascites can also develop peritonitis, which can increase their risk of infection. We don't always realize what a major role that nutrition plays in overall health and in disease progression. And with liver patients, it's especially important to maintain adequate nutrition. You want to avoid alcohol and other hepatotoxic substances. You want to teach your patient to eat a diet high in carbohydrates and moderate in proteins and fats. You want to teach them about the importance of daily weights because that's the best measure of fluid volume status. And you want to not restrict protein unless the patient is experiencing hepatic encephalopathy. Because remember, liver patients do not synthesize albumin and other plasma proteins, so they have that deficit in the protein. But when we break down protein, we're going to develop hepatic encephalopathy because we're going to have that buildup of ammonia. So you just got to find that balance. So generally don't restrict it unless the patient is at a high risk or is currently experiencing hepatic encephalopathy. You want to teach them about eating small, frequent meals. And often it's important to take a multidisciplinary approach and consult the dietitian because they know much more than we do. Students often ask me why a patient with cirrhosis, why their liver just doesn't regenerate. I want you to think about this. Does healthy tissue regenerate? Yes. But does hard nodular scar tissue regenerate? Absolutely not. So, unfortunately, for a patient with end stage liver disease, the only curative treatment is a transplant. And a patient may receive a transplant from a living or a deceased donor. With a living donor, one lobe will be donated. And since that is healthy tissue, It will regenerate, and both the donor and the recipient will have a full liver size within 6 months.
Liver transplantation has very strict guidelines on who is a candidate and who is not. Some contraindications for a liver transplant can include severe cardiopulmonary or respiratory disease, active untreatable infections or diseases such as AIDS or metastatic cancer. And it's going to be contraindicated in patients who have the inability to comply with post transplant regimen because those can be very, very, very intense because patients are going to have to comply with refraining from substances such as alcohol and drugs. They are going to have to take anti rejection medications for the rest of their lives. So there's a lot that goes into this. So anyone who may lack the social support or those who have uncontrolled psychiatric illnesses or those who are actively engaging in substance abuse are not going to be able to comply with that regimen, making them ineligible.
There are various complications that can arise post liver transplant, such as bleeding and acute graft rejection. That's why it's very important to look for those signs of tachycardia, fever, right upper quadrant pain, and other signs of acute rejection. You may see the AST and ALT rising. You may notice jaundice. Other complications can include infection, hepatic complications such as bile leakage, abscess formation, or a hepatic thrombus. Or this can lead to hyperperfusion of the kidneys, which can lead to an acute kidney injury. All right, you can wake up now. The presentation is over.